So today we're going to talk about diseases of large airways, and we'll start with a discussion of bronchiectasis. So we'll talk about the definition and the classification scheme, which is called the Reed classification, and we'll talk about diseases that can cause bronchiectasis. First of all, the definition. Bronchiectasis is the localized, irreversible dilatation of the bronchial tree, and usually it's secondary to infection. Infection is usually the common pathway in most cases of bronchiectasis. It's easily recognized on CT as the airway itself should be about the same diameter as the accompanying blood vessel, but if you notice that the airway is markedly dilated compared to the accompanying blood vessel, then you have bronchiectasis. So there is a vicious cycle of bronchiectasis that is related to recurrent infections. So what happens is with infection, you damage the mucociliary clearance system. So with that decreased ciliary function, the airways become susceptible to recurrent infection and then to damage of the airways, which results in bronchiectasis. And then that bronchiectasis also predisposes the airways to more recurrent infection. So that's how you get this vicious cycle of bronchiectasis. The types of bronchiectasis are described basically anatomically depending on their appearance, and we have these three major types that are illustrated here. We have cylindrical bronchiectasis, which is the mildest form. So here the bronchi are thick-walled and slightly dilated. The number of bronchial subdivisions is normal, going all the way out to the periphery. The smaller bronchi, though, may be plugged with secretions. Next, we have varicose bronchiectasis. So here, the bronchial walls are somewhat more irregular and beaded, as you see here. Here, there is some destruction of the distal subdivisions of the bronchi, so only 6 to 7 bronchial subdivisions are intact. And more distally, you can have bronchiolitis obliterans within these smaller airways. And then the most severe form of bronchiectasis is cystic bronchiectasis. So here you have these dilated cystic bronchi, and they can commonly get infected, and that infection then can result in these air fluid levels here that you see within the bronchi. And here we only have 4 to 5 bronchial subdivisions. So cylindrical, varicose, cystic, these are the basic types of bronchiectasis based on the anatomic appearance, and that's called the Reed classification. Now, there is an additional type of bronchiectasis that you can get from scarring, so this is called cicatrization bronchiectasis. So here's a patient who's had prior tuberculosis. You can see there's volume loss here in the right upper lobe. The right upper lobe here is collapsed, and the bronchi there are dilated. There's bronchiectasis there. So this is bronchiectasis from scarring. So this is called cicatrization bronchiectasis, or if the scarring is associated with interstitial lung disease, you could call it traction bronchiectasis. So traction bronchiectasis is bronchiectasis from scarring. So that's an additional type of bronchiectasis we can consider. So in the Reed classification, we have cylindrical, varicose, cystic, and then you can add traction or cicatrization bronchiectasis also. If you want to look at the airways, a good type of reconstruction is a MINIP reconstruction. So we're used to looking at MIP reconstructions, maximum intensity projection reconstructions for looking at vascular structures. If you're looking at airways and airway structures and air-filled structures, MINIP reconstructions, minimum intensity reconstructions, where basically you take a slab of tissue and you display the lowest attenuation voxel there within that slab of tissue. And that nicely brings out the airways here. So here we have a case of sarcoid with scarring and bronchiectasis within the upper lobes nicely demonstrated. And here's a case of interstitial lung disease, NSIP, showing you traction bronchiectasis here predominantly within the lower lobes on these coronal MINIP reconstructions. So when we talk about causes of bronchiectasis, Again, usually it's secondary to infection. So here we have listed some infections. You can get it from aspiration. You can get it from chronic obstruction like carcinoid tumors or other forms of obstruction that can lead to recurrent pneumonia and dilatation of the airways. Impaired host defense and immunity, that can cause recurrent bronchiectasis. These are some of the diseases that we've listed here. And then there are some congenital causes of bronchiectasis that we will also discuss. So if we look at a case like this and I ask you, what is the cause of bronchiectasis here? Well, we have bronchiectasis with some volume loss here in the left upper lobe. You can see architectural distortion. Here's a cavitary lesion. We have these small nodular opacities, somewhat in a tree and bud configuration. This is a patient who had tuberculosis. So this is bronchiectasis from tuberculosis. 21-year-old woman with tuberculosis. So we know that tuberculosis gives you upper lobe fibrocavitary disease. Here's a 56-year-old man with tuberculosis, volume loss in the right upper lobe, these cystic spaces and cavitary lesions and apical pleural thickening, your typical manifestations of tuberculosis. Many times, though, these cystic areas that we're looking at represent regions of bronchiectasis, as you can see here on the CT scan. So you see that these cystic areas really represent dilated bronchi here in this patient with severe bronchiectasis from tuberculosis. And with tuberculosis, in addition to the cavitary lesions, you can also have these tree and bud opacities, which represent bronchogenic dissemination of infection, nicely demonstrated here. Often these cavitary lesions can't communicate with the airway, and when they do, then the organism has access to the airway, and you can get bronchogenic dissemination, as in this example. So here's another case here, and we have some bronchiectasis in the right middle lobe here and within the lingula, demonstrated on these images, right middle lobe and lingula bronchiectasis. And when we see this, we should think of Lady Windermere syndrome or atypical mycobacterial infection, which can cause bronchiectasis in those regions. Chronic aspiration, this is another cause of bronchiectasis. So you can have dilated airways here within the lower lungs. You see some tree and bud opacities, and then bronchiectasis, some volume loss here within the right middle lobe with bronchiectasis. So chronic aspiration is a common cause of bronchiectasis, especially in a lower lung distribution. Right middle lobe syndrome, these are patients that develop recurrent atelectasis and pneumonias within the right middle lobe, and this is often due to obstruction of the right middle lobe bronchus, which can be obstructed from lymphadenopathy within the right hilum, and that predisposes the patient to recurrent pneumonias, atelectasis, and bronchiectasis in the right middle lobe. So that's called right middle lobe syndrome. Here we have the atelectasis here in the right middle lobe, and you can see these slightly dilated bronchi there within that affected right middle lobe. Carcinoid tumor, tumors can grow within the airways here. Slow-growing tumor like carcinoid can also result in bronchiectasis, as in this example here. Then here we have a case where we have this branching tubular opacity. So that represents mucoid impaction. That's a nice finger and glove sign. And if I show you this CT scan and I ask you what underlying disease might this patient have, this is a non-contrast CT, but notice we have all these branching tubular opacities within the upper lobes that are quite dense. So this is very dense mucoid impaction, and dense mucoid impaction can be associated with allergic bronchopulmonary aspergillosis. So allergic bronchopulmonary aspergillosis, this can occur in asthmatics. So the aspergillus grows within the airways, causes damage to the airways, and then these patients develop mucus plugging and bronchiectasis. So we might see consolidations, collapse, but a good sign of bronchiectasis on the plain film is the finger and glove sign, or these branching tubular opacities here. So that's representation of mucoid impaction. So with allergic bronchopulmonary aspergillosis, if we have an asthmatic with mucoid impaction and regions of bronchiectasis there within the lungs, we need to think about allergic bronchopulmonary aspergillosis in that patient. So this can also give you central bronchiectasis, perihilar bronchiectasis, as we see in this example, although in reality the bronchiectasis can be anywhere in patients with allergic bronchopulmonary aspergillosis. And the bronchiectasis can be high in attenuation because of calcium and metallic ions within the viscous mucus. So that high attenuation mucoid impaction can be very characteristic of allergic bronchopulmonary aspergillosis. Here we have a 15-year-old female. The chest radiograph shows an interstitial pattern, predominantly in an upper lung distribution. Notice, though, we seem to have these tubular opacities with thickening along the edges, so these represent thickened, slightly dilated bronchi. This is a patient with bronchiectasis here, predominantly within the upper lobes. You can see that here on the CT scan. Also, all of this inflammatory disease, predominantly in the upper lobes, these areas of bronchiectasis, tree and bud opacities here scattered throughout the lungs, telling you that this patient has some kind of active airway inflammatory disease. And if we see this in a young patient, we should be thinking about cystic fibrosis. So we know about cystic fibrosis, that it's an autosomal recessive disease. The dysfunction in exocrine glands results in viscous and tenacious mucus secretions. And so we can see air trapping manifested as emphysema on the chest radiograph. You can have enlarged hilar shadows from hyaluronidopathy from infection, or in later stages from enlarged pulmonary arteries from pulmonary hypertension. The hallmark is bronchiectasis, and it tends to be most pronounced within the upper lobes. So these patients can have atelectasis, consolidations. You can have complications from pneumothorax from rupture of a bleb, or massive hemoptysis from hypervascularity due to chronic inflammation. So if we have a young patient with these very dirty looking lungs, mid to upper lung distribution of disease, you can see these cystic and tubular shadows representing bronchiectatic airways, hyperinflation. There are increased lung volumes from air trapping. Here's a lateral view showing you all that hyperinflation, and when you look very carefully at the hilar, you can see the bronchial dilatation. On CT, we can see these dilated bronchi here. Disease tends to be worse in the upper lobes. This is an area of mucoid impaction, and when that is coughed up, the patient will be left with this dilated airway. This patient also happens to have a small pneumothorax. So here's our next case, and if I ask you what is the underlying disease in this patient, well, we notice there is bronchiectasis again, lower lung distribution, some tree and bud nodular opacities, telling you that there is bronchiolitis and some active airway inflammatory disease. But the key finding is when you look at the heart and you notice that it seems that the heart here is either displaced to the right, or maybe the apex here is on the right side. This is a patient with dextrocardia. So if we have dextrocardia and bronchiectasis, we should think of Cartagener's syndrome. So the triad for Cartagener's syndrome, situs inversus, sinusitis, bronchiectasis, that is the triad for Cartagener's syndrome. And Cartagener's syndrome comes under the heading of the ciliary dyskinesias. So this is the same as a modal cilious syndrome. It's a rare autosomal recessive. It's a genetic defect in ciliary structure and function. Results in impaired mucociliary clearance. These patients have recurrent respiratory tract infections and bronchiectasis. And about 50% of these patients will have normal situs, 50% will have situs inversus. The ones with situs inversus, we call that Cartagener's syndrome. The ones with normal situs, we just call it ciliary dyskinesia syndrome. Here's another example of ciliary dyskinesia. This patient has normal situs. There's bronchiectasis here, predominantly in a lower lung distribution, confirmed here on the CT scan. So this also belongs in your differential of patients who have bronchiectasis, especially in a lower lung distribution, ciliary dyskinesia syndrome. 50% of those patients can have situs inversus, and when they have situs inversus, we call that Cartagener's syndrome, again characterized by the triad of situs inversus, paranasal sinusitis, and bronchiectasis. Easy to recognize on the chest radiograph. You can see that the patient has dextrocardia. So dextrocardia and bronchiectasis is Cartagener's syndrome. Now, there are other immunodeficiencies that can also result in bronchiectasis. There's a whole host of them. This is an example of a patient with secretory IgA deficiency resulting in recurrent infections and bronchiectasis here again within a lower lung distribution, confirmed here on the CT scan. So any underlying immunodeficiency predisposing the patient to recurrent pulmonary infections can be a cause of bronchiectasis. Now, if I show you this case and ask you what's wrong, you take a good look at it and you notice the trachea does appear dilated here, and on the lateral view you notice this corrugated appearance to the tracheal wall. So that is a typical manifestation of Mounier-Kuhn syndrome. So Mounier-Kuhn syndrome is congenital tracheal bronchomegaly. We have a dilated trachea, and this corrugated appearance to the trachea is also very characteristic. These patients also have dilated central right and left mainstem bronchi, and they are predisposed to recurrent infections, so they can develop bronchiectasis elsewhere in the lungs from recurrent pneumonias. So Mounier-Kuhn syndrome, also called congenital tracheal bronchomegaly. These patients have diffuse dilatation of the trachea and main bronchi. 95% are males, and these patients can get recurrent pneumonias and can have chronic productive cough. This can also be associated with other connective tissue disorders like Marfan's, cutis laxa, Ehlers-Danlos, and can also be seen in cases of cystic fibrosis. So with Mounier-Kuhn syndrome, you will have a dilated trachea, and that corrugated appearance is produced by the mucosa prolapsing between the cartilaginous rings. There are some numbers here: coronal diameter greater than 26 millimeters in a male or 23 millimeters in a female, although you can usually eyeball it and tell that the trachea is too dilated. So Mounier-Kuhn syndrome, dilated trachea, dilated mainstem bronchi, that corrugated appearance to the trachea, very characteristic. Here's a volume rendered view showing you a nice example of Mounier-Kuhn syndrome. So here's our next case, and it shows these cystic areas within the lower lungs. When we look closely, we can see some air fluid levels in there. So here on the close-ups, you can see the air fluid levels in there. This is a patient with cystic bronchiectasis, and the air fluid levels are common from infection. But I will tell you, this is a rare congenital disease of airways associated with cystic bronchiectasis. What is the answer? The answer is Williams-Campbell Syndrome. This is a congenital disorder resulting in complete or partial absence of cartilage in the smaller bronchi. So the trachea, the main and proximal lobar bronchi are not affected, so these patients develop bronchiectasis more peripherally. Cystic bronchiectasis is what these patients will develop. So cystic bronchiectasis like that from a cartilage deficiency of the small airways, this is called Williams-Campbell Syndrome. So that's our discussion of bronchiectasis. Let's move on to tracheobronchial abnormalities. So in this example, we have a chest radiograph that shows a right paratracheal opacity. This patient goes on to CT. We look at the trachea, we notice something budding off here of the trachea. We look over here, it looks like we have some air bronchograms here in the right upper lobe. What is going on? This is a tracheal bronchus. And the complication of tracheal bronchus is infection or obstruction. And so these patients can develop atelectasis or pneumonia within the area supplied by the tracheal bronchus, as occurred in this example. So another example here of a tracheal bronchus. These commonly go to the apical segment of the right upper lobe. So this bronchus may represent the apical segmental bronchus, in which case it is missing when you look down lower. Or on occasion, it may be a supernumerary bronchus, so it may be an extra bronchus here coming off the trachea, supplying the apical segment of the right upper lobe. So here on a bronchogram, you can see the bronchus coming off of the trachea. So this is tracheal bronchus, also called pig bronchus or bronchus suis. So it's a bronchus usually going to the apical segment of the right upper lobe, coming off of the trachea. And as we've said, complications can be atelectasis or pneumonia from obstruction, especially if the patient is intubated. So you can imagine if the patient is intubated, how you can develop atelectasis of these segments supplied by the tracheal bronchus. Here's another bronchial abnormality. This bronchus coming off medially here from the bronchus intermedius. And you can see that it is blind ending. So what do we call this when we have a blind ending bronchus like that coming off medially from the bronchus intermedius? This is called a cardiac bronchus. So this is quite rare. It's directed towards the heart. It's usually a blind ending bronchus. This can arise from the medial aspect of the right main bronchus or the bronchus intermedius. Here again, we have another abnormality here next to the trachea. In this case, we can actually see the communication with the trachea, which is quite rare. Usually you don't demonstrate that communication. So what does this represent? This is a tracheal diverticulum. So these are also quite common. You can notice these usually at the thoracic inlet here towards the right posterior aspect of the trachea. So this is called a tracheal diverticulum. And as I've said, usually you're not able to demonstrate that communication with the trachea, but we were able to do that in this particular example. Okay, so moving on, here we have a patient who has a mass here within the trachea. So what is the most common tracheal neoplasm? The most common tracheal neoplasm is squamous cell cancer. Here we have another patient who has this irregular thickening of the trachea, somewhat mass-like. You can see, and it seems to be extending submucosally along the trachea. This is another type of neoplasm. This is adenoid cystic cancer. So adenoid cystic cancer can give you irregular thickening of the trachea and can extend submucosally. This is the second most common primary tracheal neoplasm. So when we talk about tracheal neoplasms, the most common is squamous cell cancer. The second most common, adenoid cystic. Mucoepidermoids can also occur. These arise from the adenoid cystic, and mucoepidermoid arise from salivary gland rests. That's why they have the same cell type as salivary gland tumors. There are additional types of neoplasms that you might see in the trachea also, although these are rare for metastatic disease, renal cell melanoma. Also, lung cancer has a propensity to metastasize to the trachea. So squamous cell cancer is the most common primary malignant tumor of the trachea. It's associated with smoking, can present as tracheoesophageal fistula. Adenoid cystic cancer, this is the second most common tumor neoplasm of the trachea. This is not smoking related. This tends to spread submucosally, as you see here, and it can give you this very irregular thickening of the trachea. Mucoepidermoids, these are more likely to occur within the major or segmental bronchi than the trachea, but this can be another type of tracheal neoplasm. Here's an example occurring within segmental airways. So this is growing within the airways, an example of a mucoepidermoid tumor. Here's one that happened to be within the trachea, mucoepidermoid tumor of the trachea. Now, if we have a filling defect like this within an airway or a segmental airway here, this one is causing left upper lobe collapse. So what kind of neoplasm do we think about here? Again, squamous cell is the most common, but carcinoid tumor is another neoplasm to consider. Remember, carcinoids do not occur within the trachea, but they can occur here within the more distal airways. So this was an example of a carcinoid tumor. Metastatic tumors can also affect the airways. We've discussed some of them. Breast, renal, lung cancer, melanoma. These are all tumors that can metastasize to the airways. Now, what if you have a case like this where we have kind of small lesions affecting the airways here with cystic changes within the lungs? So what are we thinking about there? That is squamous papilloma. So nowadays we see this in adults associated with HIV. So there are other types of tumors that might also occur in the trachea, especially in children. Hemangiomas can occur. It's the most common tumor in children to occur within the trachea. Then we can also have other types of tumors like hamartomas, and there are other causes of tumor-like conditions of the airways, like inflammatory granulomas, and amyloid can also occasionally do that. So squamous papilloma, this can also occur within the trachea, and Tracheobronchial Papillomatosis associated with HIV. This can give you these papillary lesions within the trachea and also cystic lesions like this within the lungs, which can transform to squamous cell carcinoma. Here's a patient who has right middle lobe atelectasis because of this obstructing lesion here within the right middle lobe bronchus. We notice it is fatty in attenuation. This was a hamartoma. This was an endobronchial hamartoma. So these may also have fatty components, as in this example. Other inflammatory conditions like granulomas can cause stenosis of the airways, as in this example, and amyloid also can grow circumferentially around the airways and might be also associated with airway obstruction. So here we have a 33-year-old man with stridor. We look very carefully here at the airway, at the trachea. We notice there are some clips here on the right side of the neck, so this patient has had some surgery. But you'd also notice this irregularity here in the tracheal air column. This is a patient with tracheal stenosis. So this patient developed stridor because of tracheal stenosis, easily demonstrated here on CT. You can see the irregular thickening of the trachea, the irregular thickening of the wall, and the stenosis. So this is usually secondary to scarring of the trachea from prolonged intubation. So post-intubation tracheal injury, focal stricture of the trachea can occur from the tube balloon on the cuff on the tracheostomy tube, causes pressure necrosis, which causes fibrosis and a stricture. This usually presents weeks or a few months after extubation with upper airway obstructive symptoms. Look for narrowing of the trachea on chest radiograph. Easy to demonstrate on CT, as the stricture is well demonstrated, especially on your coronal and sagittal views. If you're looking at radiographs from the intensive care unit and you notice this ballooning of the trachea here, it means the cuff on the endotracheal tube is overdistended. Make sure you call them and tell them to take down that cuff, because this can result in injury to the trachea and tracheal stenosis a few weeks after extubation. So here's another example of an irregular tracheal stricture here, thickening of the wall, the irregular shape of the trachea as a result of prolonged intubation. Nice volume rendered view here showing you how that can affect the airflow there through the trachea. And then here is a virtual bronchoscopy showing us as we're traveling down through the stricture within the proximal trachea. Now, what if the trachea looks like this? So here on the frontal view, it does appear narrowed, but you notice here that at the thoracic inlet, it is increased in AP diameter, but narrowed in width. So what is this called? This is called a Saber-Sheath Trachea. So these patients have an abrupt change in the caliber of the trachea at the thoracic inlet. It will be normal in diameter higher up, and then as you travel through the inlet, then you get that Saber-Sheath shape of the trachea. It's usually associated with COPD, probably due to abnormal intrathoracic transmural pressures from COPD, producing that narrowing of the trachea, but it's recognized because on the in the AP dimension, the trachea is widened, even though it is narrowed there in width on the frontal view. So this is Saber-Sheath Trachea. Now, what about a case like this, where we have this kind of nodular thickening of the tracheal wall, some calcifications there? Notice that it spares the posterior wall. So what is this condition called? This is tracheobronchopathia osteochondroplastica. So this is osteocartilaginous transformation there of the tracheal wall, and it spares the posterior wall because there's no cartilage there. And so you can see these tracheal calcifications on CT, these calcified nodules about 3 to 8 millimeters in diameter, producing that irregular narrowing of the lower trachea. The posterior tracheal wall, again, is spared. Usually it's asymptomatic. Usually this condition is asymptomatic, and it may be usually an incidental finding. Now, what about a case like this, where we have tracheal narrowing that also extends to the main stem bronchi? Again, the posterior wall here is spared. So this is an inflammatory condition, a diffuse inflammatory condition of the cartilage. So this is relapsing polychondritis. So this affects the cartilage throughout the body. So this cartilaginous inflammation then can result in destruction and weakening of the cartilage in the trachea, resulting in narrowing of the trachea and thickening of the wall because of the inflammation of the cartilage in these patients. So the respiratory tract is affected in about 50% of patients with relapsing polychondritis. These patients can develop diffuse tracheal narrowing from thickening of the anterior and lateral walls with sparing of the posterior wall. So relapsing polychondritis, and this can extend down to the main stem bronchi, and because of the weakening of the tracheal walls, these patients can develop collapse of the trachea, resulting in airflow obstruction. Now, what about a case like this where we have some irregular thickening here of the tracheal wall? Here it seems to extend to the left main stem bronchus. And this patient also has sinusitis. How do we put those findings together? Tracheal abnormality associated with sinusitis. So Wegener's granulomatosis or granulomatosis with polyangiitis. So this is a systemic necrotizing granulomatous vasculitis that can involve the trachea, usually involves the upper respiratory tract, and the tracheal lesions can be focal or diffuse. Patients can develop diffuse wall thickening, and it can be circumferential. So here's the patient at presentation. Trachea does not look so bad. 3 years later, developed this tracheal wall thickening as a result of granulomatosis with polyangiitis affecting the trachea in this case. So diseases that spare the posterior wall, TBO, relapsing polychondritis because of the lack of tracheal cartilage. Diseases that cause circumferential narrowing of the trachea, you can see that in amyloid or Wegener's granulomatosis. So other lesions that can cause narrowing of the trachea, we can see it with granulomatous disorders like sarcoid. This can affect the trachea and can also affect the mainstem bronchi, as in this example. Tuberculosis, of course, this can also affect the trachea and can also affect the airways from inflammation, scarring, and can cause strictures. Now, what about this case? So as we scan through this patient's chest, we notice that there is quite a bit of emphysema here. When we look at the airways, though, we notice that the airways appear to be changing in caliber as we travel down. So as we go down, we can see the trachea is open and then closed and then seems to narrow and then open again. And then as we come down lower to the mainstem bronchi, they get lower. So what is happening here is that the patient is breathing during the scan, and as the patient is breathing, the airways are collapsing in expiration. So this patient has a condition called tracheomalacia or tracheobronchomalacia in this case, as it extends down to involve the mainstem bronchi. So because of that weakening of the cartilaginous walls of the airways here collapse in expiration, and so you can see that they are changing in caliber during the scan as the patient is breathing during the scan. So normally on expiration, there is some collapse of the posterior wall, as you see in this example. Inspiration, trachea nice and round. Expiration, a little bit of collapse here of the posterior wall. Here's the soft tissue window showing you the same thing. Inspiration, expiration, a little bit of collapse there of the posterior wall. Usually less than 50% though. Usually it decreases the cross-sectional area by less than 50%. And here on this dynamic CT, as the patient is breathing, you can see the normal collapse there of the posterior wall with inspiration and expiration in this particular case, okay? But what happens with tracheomalacia is because of abnormal weakening of the tracheal wall and the destruction of cartilage and expiration, the trachea collapses almost completely, as you can see in this example, that the trachea is changing in caliber throughout the scan as it is collapsing during expiration. So this decreased compliance of the tracheal wall or the airways is because of damage to the cartilage, and that causes narrowing of the trachea in forced expiration. So it's very important to do forced expiratory imaging if you are looking for this when you're doing your CT scan. So there are many causes of tracheomalacia. It is commonly associated with COPD, probably because of chronic inflammation of the cartilage resulting in destruction. But there are many other diseases that can cause destruction of cartilage and can cause tracheomalacia. So the frown sign here on expiratory imaging, the frown sign is a manifestation of tracheomalacia. Here on virtual bronchoscopy, here you can see the collapse of the posterior wall, and on real bronchoscopy, this is also what the bronchoscopist looks for, an expiration, that collapse of the posterior wall. Here's a sagittal reconstruction showing you the same thing. So it's very important that you do dynamic expiratory imaging if we are looking for this. We ask the patient to forcibly blow out the air while we are doing the CT scan, looking for that collapse of the trachea. So sometimes it can be circumferential. So on inspiratory images, the trachea may look normal, but if you're looking for this, you want to do expiratory imaging, as in this example there. Okay. Now, it turns out that there can be, sometimes in normal patients, a significant amount of collapse of the trachea. In this particular study, about 78% of healthy volunteers demonstrated greater than 50% reduction in the cross-sectional area on forced expiration. So you have to be careful in terms of interpreting the sign. You don't want to interpret these things in isolation. So if the patient is symptomatic, then we would take it more seriously. And if you have this, especially this marked collapse with the frown sign, then it is probably a real finding. You can also have lunate configurations there. So the traditional CT criteria was that it was considered abnormal if the lumen narrows by greater than 50% on expiration. But given the range of collapsibility in normal individuals, it's probably better to use a threshold of 70%, greater than 70% expiratory collapse, and you still need to correlate with clinical symptoms, cough, dyspnea, recurrent infections, risk factors, etc., and pulmonary function tests. So be careful about interpreting this sign in your diagnosis or making diagnosis of tracheomalacia. So if the narrowing extends down to the main stem bronchi, or the disease extends down to the main stem bronchi, then we call it tracheobronchial Papillomatosis. All right, now what about this example? We have this circumferential tracheal wall thickening, and this also extends down to the main stem bronchi. A little bit of calcification there within the wall. What could this represent? This is amyloidosis. So what happens with amyloid, this is a protein that forms these polypeptide chains, form a beta-pleated sheet. That beta-pleated structure makes it resistant to proteolysis from macrophages. Hence, this amyloid can accumulate throughout the body, and there are forms of this disease when it can accumulate within the lungs and the airways. Amyloid is the Greek word for starch. So the pathologist looks for it with this Congo red staining, and also this light red, stains light red with apple green birefringence and polarized light. That is a pathognomonic finding also for amyloidosis. Now there are different forms of amyloidosis. There's the systemic amyloidosis, where we get deposition of amyloid as part of a systemic disease. So here the amyloid can be found in subcutaneous fat, in the kidneys, heart, bone marrow, and that can be classified based on the composition of the protein. You can have AL amyloidosis, which is light chain, and that's associated with neoplastic conditions. You can have AA amyloidosis, amyloid A, which is associated with inflammatory conditions. We have localized amyloidosis, where the amyloid is deposited within an organ not associated with systemic disease. So primary pulmonary amyloidosis is when it is confined to the pulmonary system, and tracheobronchial amyloid there is the most common form of that. We can also have nodular parenchymal amyloid, where we get amyloid nodules within the lung parenchyma. There's also interstitial disease, where we get alveolar septal amyloidosis, and it can also accumulate within lymph nodes. So for systemic amyloidosis, with AL amyloidosis, we can see that with neoplasms, as these that are listed here. And then you can also have systemic amyloidosis associated with chronic inflammatory conditions, as I have listed them here. With systemic amyloidosis, most patients who have lung involvement on pathologic examination usually do not have clinical symptoms. Renal failure, nephrotic syndrome, cardiac disease are the most common clinical manifestations, and the amyloid tends to deposit in the lung interstitium along the alveolar septa, and of course these patients might have dyspnea if they are symptomatic because of lung disease. So with systemic amyloidosis, they might have some interstitial abnormalities, they might have some adenopathy on CT. You might see small nodules in interstitial thickening, but with amyloidosis involving the interstitium of the lung, this can give you perilymphatic nodules, as in this example. So this is a rare cause of perilymphatic nodules here within the lung. Realize, though, that sarcoid lymphangitic tumor, those are much more common in terms of causes of perilymphatic nodules in the lung, but amyloid can give you perilymphatic distribution of nodules in the lungs, small nodules. Now, localized amyloidosis, the most common form of that affects the lung, usually affects the tracheobronchial tree. That can be diffuse or focal. And as we said, we can have nodular parenchymal amyloid, where we get nodules within the lung parenchyma. Here also we might have interstitial disease, and we can also have amyloid within lymph nodes within the chest. So for tracheal bronchial amyloidosis, you can have diffuse involvement where you get concentric nodular thickening of the tracheal or bronchial walls. So here you can see this diffuse thickening of the tracheal wall extending down to the bronchi. We might get some calcification, and this does not spare the posterior wall. Another example here where we have some circumferential narrowing there of segmental airway. Now, with nodular parenchymal amyloidosis, here you can have nodules within the lung parenchyma, and calcification is also common within these nodules, and they might grow slowly over many years. This is a rare disease, but if we have multiple nodules of various sizes and shapes that grow slowly, you might think of nodular parenchymal amyloid. Here's an example, this nodule here within the lung. So this may remain stable for years or may grow very slowly, and you might have calcification associated with that. Another example here, multiple nodules scattered throughout the lung with calcifications, nodular parenchymal amyloidosis. Again, interstitial disease can also be a manifestation of amyloidosis affecting the lungs, and this can give you reticular opacities with interlobular septal thickening. You can have a micronodular pattern, again with somewhat perilymphatic distribution. So here we see this interstitial thickening and some nodular thickening of interlobular septae, again in a perilymphatic distribution. So interstitial disease from amyloid can give you a perilymphatic distribution of disease. Okay, so that is our discussion of diseases of the large airways, and I thank you for your attention, and we will see you next time.